So today we're going to be going through the setup for a Minnesota tube and inflation of both the gastric and the esophageal ports. The most important thing about this is thinking about how to set up, just like we would for any other procedure, and so getting all the equipment that you need. So we're going to walk through all the different equipment here. So we have a basin of ice water, either a 500 or 1 liter bag of normal saline, which is going to be your anchor for the tube, with a roll of Kerlix. You are going to need 4 Kelly clamps, which you will get from the ICU typically. And each of the Kelly clamps should be taped. The blades should be taped so it doesn't create any injury on the tube itself. And then you're going to have both a piston syringe as well as a lure lock syringe. You're going to have at least 3 different stopcocks and a sphygmometer if you're going to be using the esophageal balloon. And then last, but of course not least, your Minnesota tube as well. Kind of going through the tube here, you have your gastric balloon on the end and your side holes of the tube, which will be positioned in the stomach itself. And then you have your esophageal balloon, which many times we don't even need to inflate, but you do have that for added hemostasis. You have markings on the Minnesota tube going up to 50 centimeters. And then you have your various ports. And so the first port is the stomach balloon port. And there are 2 different connections to this port. These plastic caps actually come in the packaging. And so before you manipulate the tube, you're going to want to remove all 4 of these plastic caps because they don't hold air effectively on their own. This is just part of the storage. And then you also have an esophageal balloon port, and you have 2 plastic caps here that also need to be removed. And then at the very top of the tube, you have your gastric aspiration port, and then you have your esophageal aspiration port. So this is all of the equipment that you would need. So now we're going to work through the various steps in placing the tube. So you would have a patient who's having a refractory variceal bleed. They would be intubated at this point. So the first step is that you want to place the tube in a bucket of ice water. And this is to stiffen the tube so that it will pass more easily. When the tube is submerged in the water as well, you can test the various ports and balloons to make sure that everything is inflating appropriately as well. So after you have tested all of the balloons and the aspiration ports in the bucket of ice water to make sure everything is working properly, you also want to have a system of Kelly clamps in place, closing off each of the various ports in order to ensure that the entire system remains closed. So again, each of the storage caps have been removed, and then you have a Kelly clamp on both of the openings of the gastric balloon as well as the esophageal balloon to ensure that this is a closed system. Then you are going to lubricate the entire tube to be able to pass it forward. You're going to try to pass it all the way to the 50 centimeter mark. After that has been performed, then you will want to take your piston syringe and then connect it to your gastric aspiration port. And then you're going to pass air through that port, and you're going to have a helper oscillating on the area of the stomach so that they can hear the whoosh of air to know that the tube is in the appropriate position. Once you've confirmed appropriate position based on oscillation, then you are going to start to inflate some air into the stomach balloon. So you take this down, and then you're going to insert 50 cc's of air into the balloon. You have to reclamp the Kelly clamp so that it remains closed system and you keep the air in. And you can see by looking at the balloon that it's not terribly large. So if by chance this was positioned in the wrong area, this wouldn't create any damage. And so the last supply that you need that we didn't discuss before is you absolutely have to have an X-ray technician on standby in the room ready to go because you're going to have to take a series of X-rays. So at this point, then you would take your first x-ray to ensure that the gastric balloon is insufflated within the stomach and that you have appropriate position. If you have appropriate position, then at that point, you would continue through the exact same process of insufflating 50 cc's of air into the stomach balloon until you insufflate it somewhere between 400 to 500 cc's. And as the balloon has been insufflated to no greater than 500 cc's of air, then at that point, you would take a second x-ray, confirm that the balloon is still in the appropriate position. And if it is in appropriate position at that point, then you are going to pull the entire tube taut so that this balloon is sitting at the gastric esophageal junction and pulling tension on the junction to tamponade off either your esophageal or your gastric variceal bleed. You will then take an additional x-ray at this point to confirm that that balloon is sitting right at the G junction in the appropriate position. When you are pulling tension against the G junction and you've confirmed placement with your x-ray, you have to secure that in position. And so that's where your Curlex is going to come into play with your bag of saline. So you will essentially take the Curlex and you will tie it around the tube itself. You will then tie it around the bag of saline, and then you will drape it over a trapeze in the room so that it is pulling tension on the tube at the mouth. Then you will start to aspirate through the gastric port with the adapter, a Christmas tree adapter hooked up and then hooked up to your suction canister. And if you start to see that the blood is clearing with time, and you may have to continue to kind of aspirate and inject water into the gastric balloon to do a lavage of sorts, you should see that there's a clearance of blood. If you see a clearance of blood, that means that the tamponade effect has been effective. If you are not seeing that clearance of blood, then you know that you potentially have to insufflate your esophageal balloon for additional tamponade effect. And so now we'll begin to prepare for the esophageal balloon should you need that as well. Okay, so now we are going to focus on the esophageal balloon, and this is the setup that you're going to need. And this may require you to go to a couple different spots in the hospital to make sure that you have the right equipment. But you're going to need a separate syringe. This is a Luer lock syringe, so this syringe has kind of a screw component on the end that will twist into a stopcock. And then you're going to need a series of three different three-way stopcocks. One of those stopcocks will be connected to the esophageal balloon port. And then you are going to have a sphygmometer, which is connected through pressure tubing to one of your stopcocks as well. And so this is the overall setup that you will need. You will use these stopcocks to be able to insufflate air into the esophageal balloon and then be able to measure the pressure within the balloon itself using your sphygmometer. And the reason this is important is because you are titrating, as opposed to the gastric balloon where you're titrating to a certain volume, the esophageal balloon, you're titrating to a certain pressure. And because if the pressure is too high, it can create esophageal necrosis. If it is too low, it won't create a tamponade effect. So in this situation, what we would do is, first off, we want to make sure that all of the gas is out of the system so that the sphygmometer will go back down to 0 in terms of gas. And then we are going to insufflate air into the balloon. And so you're going to take down your Kelly clamp in this situation. And I'm going to insufflate 10 cc's, close this off, open this up. We see that there still is not much pressure here. 10 cc's, open this up. We see that the pressure is starting to go up to 20 millimeters of mercury. I'm going to put another 10 cc's in. And we see that the pressure has now risen to above 20 millimeters of mercury, close to 30 millimeters of mercury. And then if we were to do even another 10 cc's, we can see that the pressure now has gone up to 50, which again would be too high at this point. And so once you've insufflated a certain amount of gas, you want to be more careful in insufflating smaller amounts of air into the balloon in order to achieve a pressure of somewhere between 25 to 45 millimeters of mercury. If you're exceeding 45 millimeters of mercury, then the risk of esophageal necrosis will start to go up. Once you've gotten your balloon to a pressure that has achieved hemostasis, and again, you want the minimum pressure doing that, you want to think about how long the balloon is being inflated. So every 6 hours, you should think about deflating the esophageal balloon for at least 5 minutes to minimize the risk of esophageal necrosis. And secondly, you want to gradually decrease the pressure within the balloon. So every 3 hours, you should be aiming to try and reduce the pressure in the balloon by about 5 cc's, 5 millimeters of mercury. Again, trying to avoid keeping the esophageal balloon inflated for longer than 24 hours.